we're using a low dose, and we will so far we haven't seen any major toxicity. Obviously we don't know who's on lithium or who's on placebo, but so overall there have been some adverse events, but nothing dramatic. So gaining confidence that a low dose with low blood levels would work, I think would increase the likelihood of physicians prescribing lithium. Certainly psychiatrists and geriatric psychiatrists would have no hesitation, since they're very familiar with the prescribing of lithium. I think neurologists traditionally have stayed away from lithium because of its neurological toxicity. So I'm not too sure about that, but if it is effective at low doses, and we demonstrate that at the low doses with low blood levels, toxicity is not that much of an issue, it'll work. I should point out that the books say you got to give lithium at a higher dose to maintain certain levels. So for example, in our pilot work, one of the patients we treated successfully was transferred to the neurology clinic, and the neurology resident after a little while looked up the books, raised the dose to the therapeutic level needed in bipolar disorder, and the patient became toxic. So more than the drug, if it does really work, the dose and monitoring blood levels to make sure they don't get too high will be very important. This is a phase 2 trial with 80 patients. If it is positive, we will need to go to a much larger trial, which may also be funded by the National Institute on Aging, depending on how the results are and how it is reviewed. So this trial is not considered a definitive trial, but it is very important in the development, because if it is negative, then I think we would simply stop, because since lithium is a fairly toxic drug, it makes no sense to proceed if this shows no effect. But if it shows some effect, we probably will try to proceed to a larger trial. I think when it comes to treatment of agitation, or for that matter psychosis and Alzheimer's, one of the first things which is often not done is behavioral management in dealing with the patient via the caregiver, because a lot of the problems, especially with agitation, can be attributed to the caregiver not understanding what's really happening and not knowing how to cope with it. So I think that is one factor. And then medications, if non-pharmacological treatments don't work, would be worthwhile. Biomarkers, nobody has been able to come up with very good biomarkers for psychosis or agitation and Alzheimer's. And one of the difficulties with biomarkers in this patient population is it's very difficult to get them into a scanner if they're agitated or aggressive, and to do a long scan, say with an amyloid PET scan. It's practically not feasible for most of these patients. So for those reasons, the only biomarkers that could be useful, which we haven't yet found, are say blood-based biomarkers or something simple that does not require the patient to cooperate for long periods of time.